thank you for giving us the opportunity to share our data concerning opportunistic screening of osteoporosis. A few words concerning osteoporosis first. It's a main cause of bone fragility. It is responsible for a number of fractures which are even spontaneous or after a very low trauma such as a fall from a standing height. We are facing a huge increase in the number of falls because of the aging of the population, and so we will have more and more fractures. And some of these fractures, mainly the vertebral fractures and the hip fracture, are responsible for morbidity and even mortality. And definitely osteoporosis is a very strong determinant of postmenopausal women's health. So we have good news and bad news. The good news is that we are able to measure the bone fragility by using bone densitometry, and these devices are very easily available, but they are underused for different reasons, mainly because of practicity. And the second point is that we have treatments which have shown that they can decrease the risk of sustaining fractures by 50 to 80% in placebo-controlled prospective studies of appropriate methodology, but they are not prescribed. And in a study we conducted in the National Health Database, SNDS, in more than 300,000 patients hospitalized for severe fractures, actually in the year after the hospitalization, only 60% of these patients received the treatment against osteoporosis. So we are facing what we called 5 years ago the crisis of inadequate treatment in osteoporosis. There are several reasons for that, and among them, first, the screening, low rate and very expensive. Two, the underreporting of vertebral fractures, even if they are perfectly legible on X-rays. And three, at the end, the lack of time and awareness from the physicians. So this is the context in which we can think about opportunistic way to diagnose and screen osteoporosis. What does that mean, opportunistic? That means that we will use parameters on images and exam which have not been primarily prescribed for that indication. So typically, you have an abdominal scan because of a problem of liver or kidney. There is no problem by chance on these organs, but you have also the spine, which is perfectly legible. And as you can imagine, with the methodology we are talking about this morning, it is very easy with very intelligent algorithm to detect the vertebrae, to segmentate the vertebrae, and to design areas of interest in which you can measure some parameters, such as the attenuation of X-rays in Hounsfield unit, which is a proxy of bone mineral density. And as you can see on the spine, this parameter is decreasing with age, of course. And on the other hand, you can also segmentate the vertebrae, recognize the vertebrae, diagnose the vertebral deformities and fractures, and this will be done without any cost, without any added irradiation, without any added time for the patient and for the physician. And so you have thus the opportunistic way to diagnose vertebral fractures and osteoporosis. The problem is, what can I trust these results as a physician? That is, in my clinical practice, can I use these fully automated parameters for the care of my patients? And for my clinical research, can I use these parameters in very large databases which are obviously available? To answer this question, we designed a study to assess the predictive value of these parameters on the outcomes, which are first, the incidence of osteoporotic fractures necessitating hospitalization, so the most severe one, and two, the prediction of mortality, because we know that the higher is the severity of osteoporosis in population, the higher is the risk of mortality. So can we confirm these two important outcomes with these fully automated parameters assessed over 3 years? So here is the flow chart. We use the PACS of Assistance Publique, which is the database of all the images produced in the hospitals of the Assistance Publique Hôpitaux de Paris. We selected patients during a period of 7 years, having an abdominal scan for any medical reason on which the spine was legible, and we selected males and females aged more than 60 years in order to be sure to have events, obviously. We selected only patients who were hospitalized at the time of the scans, and then we matched, or we tried to match with SNDS. You can imagine that this arrow was quite difficult to obtain, and we had a number of failure in matching, mainly to be sure to preserve the anonymous aspect of this link. Then we excluded patients with cancers and other bone diseases in order to be sure that the fractures were actually related to osteoporosis. And thus, we had a database of 46,000 patients aged more than 60 years with all the SNDS database for these patients over 3 years. We got a number of fractures and death, obviously, during this period. You have the numbers here, and you can appreciate on the right part of the slide that numerically, patients who had a vertebral fracture on the scan had more fracture and more death than the others. Please keep in mind that this diagnosis of vertebral fracture was automatically performed. There was no physician intervention at any step during this process. We assessed the risk of getting an incident fractures by the area under the Roux curves, and using the 4 parameters which were automatically generated by the scans, that is age, sex, bone score, and presence or not of vertebral fracture, we got an area of roughly 0.7 for all the fractures and for the hip fractures. And with that, we designed a nomogram, that is a calculator which was able to calculate at the individual level the probability of sustaining an incident fracture over 3 years. The prevalent vertebral fracture, again diagnosed by the algorithm, was a strong predictor of the incidence of osteoporotic fracture necessitating an hospitalization over 3 years. Here are the data. You have all the different location of fractures, hip, all fractures, non-vert and vert. The dashed line is in the patient without fracture according to the algorithm at baseline, as compared to the others. You can appreciate that there was a huge difference in the incidence of fractures necessitating hospitalization over 3 years in patients with a vertebral fracture detected by the algorithm at baseline. And this is the mortality. There was a high rate of mortality in patients with vertebral fracture on the scan. You have here the odds ratio, the hazard ratio, and even after adjustment on the different comorbidities and risk factors very well known from the SNDS, this hazard ratio was still statistically and clinically significant. Thus, from this data, we conclude that it is possible to use opportunistic parameters for assessing the outcomes of patients with osteoporosis, both males and females. So now we can apply that to all the diseases which need repeated scans during follow-up, typically chronic pulmonary diseases, chronic gut diseases, and so on. And there is a current application for that in the program of screening of pulmonary cancers, especially in females, because it is an unmet need in this population. So there are some data here from Chinese, 50,000 patients with opportunistic screening of osteoporosis at the thoracic spine during the screening of pulmonary cancers, with a huge prevalence, actually higher than expected in this population. And the current study is ongoing in France, looking at the same population, males and females, aged more than 60, and at risk of having both pulmonary cancers and osteoporosis. And of course, we can go beyond, because if we can segmentate perfectly the vertebral bodies, we can segmentate anything on the abdominal scans. We have access to the different organs, to the fat, to the muscles, to the vessels, and so on. And in my specialty, we are particularly interested in sarcopenia. So sarcopenia will be the next step in order to assess through the muscles, which are perfectly legible on the scans, what parameters should be assessed in order to predict falls and even mortality related to sarcopenia. So to conclude, first, as you have maybe not noticed, we assessed only patients who were hospitalized at the time of the first scan. So we have the necessity to confirm that this is true in an ambulatory population, and we do not have any cost-effectiveness analysis. But clearly it is a promise to improve the detection of high-risk patients against I would like to stress again that all the attempt we have to screen populations based on clinical risk factors, on bone densitometry and so on, which have been done very precisely in Great Britain, Netherlands and Germany, actually failed in order to demonstrate that they can decrease the risk of fracture in patients selected through this screening. So clearly we need a new way to screen this population. It is a way to address the problem of time pressure and lack of awareness of physicians, and clearly, if cost effectiveness is positive, this will dramatically transform healthcare in the domain of osteoporosis. Thank you.
Thank you. Do you have some question?
So, thank you. Very promising. So what would be the next step if you do this kind of opportunistic screening? Would you see that you add some information at the end of the compte rendu saying the opportunistic screening have shown that this person has osteoporosis and do what is needed? Or how could you see that this could be used?
Fortunately, I'm not a radiologist. But the dream of a radiologist is to say, well, I will have a report of my scan saying you were checking for liver cancer. The answer is no, there is no cancer. But the risk of osteoporosis is, the risk of sarcopenia is, the risk of cardiovascular disease is, and so on. And we will have a high number of risks which can be automatically calculated on all the images that we produced with a very, very large amount, as you know, every day. So the dream of a radiologist is to say one total body scan prediction of everything. So far it's a dream, because the next step is, okay, but at the individual level, how can I do that? What is the real score with a higher sensitivity, specificity, and so on that I can use? For example, in our study, the prediction of all fractures, the best threshold was 111 Hounsfield. But if I want a screening with a very high specificity, say 95%, the level is around 60. So that means that we may need scores applied to the problems we are facing. And by the way, as you know, it is very difficult in medicine to take a decision on only one score, and we need to have a multivariate score. So this will be the next step. And if I can add something else, we do not know today if we can treat patients based on that, because so far all the patients are treated because they have fractures or because they have low bone density on bone densitometry. So we need first models. And it is very easy to design models with that, showing the and we can change the efficacy, we can change the adherence, we can change different parameters in order to get the result. And two, we need cross-checking between bone densitometry results and that.
Thank you, that was fascinating. I have a question though about consent. Actually, if I'm scanned for a suspected liver lesion and I'm being informed of my risks, which are not life-threatening immediately, actually, aren't you worried that people are burdened with information that they've never asked for?
Yes, it is a terrible ethical problem. The best way is to inform the general population that with one exam we can do a lot of things. So the information must be very large, and it is the case now in my hospital or in the hospital in Paris. All the reports contain a statement saying that except if you give your position, all the data we get during the hospitalization can be used for research. So in that way, by information of all the population, we may obtain that. But the point is very important because 10 years ago, we had the same problem with genetics. And we have seen a number of colleagues in genetics saying, give me a blood sample and I will predict everything, cancer, Alzheimer, and so on. This is, from an ethical point, not possible. So you're right, we have to check for that. But as I said, it is a radiologist's dream, not a physician's dream so far.
Thank you so much for such an interesting topic. As I understood, so the main idea is to detect the patients with a high risk of fractures. So did you have a chance to compare the ability of this tool, screening tool, with the FRAX score? That is the main score to detect patient at high risk and very, very cheap.
Yes, the FRAX is a composite index of 12 clinical risk factors, and by the calculation, it allows to obtain the individual risk of fracture based on these clinical risk factors. That's right. Yes, there is one study published in Nature Medicine in 50,000 patients. In this study, the investigators compared the FRAX and the results of opportunistic screening, and the area under the rock curve was exactly the same. So not better, but not less, exactly as the current standard of clinical assessment.
Thank you very much.